Okay, then Happy New Year to all of you. So this is the first talk of this season in this new year. And the talk is about the role of rTMS in Parkinson's disease. I think this is probably my 7th talk in this series of role of rTMS in various neurological and psychiatric disorders. And I have to admit that I'm not very satisfied with the results of TMS in Parkinson's disease. The first patient I ever advised TMS was a patient with Parkinson's disease. That was about 3.5 years ago. This young lady, she had come from Middle East and she was having a tremor. And that was our first case in our center. That was March 2018. That is almost 4 years back. So this lady, we gave her 30 sessions of TMS and dramatically her tremors improved a lot, and also her mood improved. So definitely the depression component went away and there was improvement in tremor, and patient was delighted. This lady was from Middle East, as I mentioned, and she gave us she was so grateful to us. She was so grateful to us, and this case motivated us to do TMS, to take up TMS. This was our first case that this is the first case that we started, and she completed all 30 sessions. And since then, after that initial case, after that initial enthusiasm, we did for about 20 cases, but the response has not been satisfactory. Neither was I satisfied, nor the patients. So let me just, this background, let me get started. So, obviously I'm very interested in TMS, both professionally and personally, because it is part of my clinical practice. And so we have taken up TMS in our part of the country very early. So it's going to be 4 years since we have first started doing them. So we are, it is a personal also an accomplishment for me. So we have been doing TMS for almost now close to 4 years. 1,500 patients have got TMS therapy in our center. So, okay. So the clinical features of Parkinson's disease are, I think depression is also part of Parkinson's disease. It may be primary or it can be secondary to the physical problems that these patients have. So they all also have, rigidity and tremor. And later in the disease, they have an on and off effect. So they're on when the medicines are, the serum levels of the medicines are there, and off when the serum levels of these medicines drop in. And later in the disease, the side effects of the drugs start. In our cases, we have recorded all our patients' data, and adverse effects were noted. Baseline neurological and psychological assessment has been done. And these patients have been followed up for at least 1 year. We didn't have any adverse events because we have followed the guidelines, the applicable guidelines. We have used the ABS protocol, which consists of, for Parkinson's disease, we use both hemispheres. We inhibit both hemispheres. So we use a frequency of 1, 90% of the motor threshold, and 900 pulses for each level we use. And then left DLPFC we use 120% empty, frequency 10, and 900 pulses, and interval again of 10 seconds. So we stimulate 3 different areas of the brain for these patients. So what we have realized is you shouldn't give any time horizon to these patients. Should tell more is better. Spasticity or rigidity improves first, walking improves to some extent, cognition improved in all, sleep improves in all. The patients who have some sort of dysphagia, they improve. But last thing, very hard to improve is tremor, especially if it is late in the disease. We didn't have satisfactory results with improvement of tremor in these patients. So overall, I would say that though the results have been small and do exist, I think it is not a very satisfying treatment. I think the main treatment would be medicines and deep brain stimulation. which is again a some form of stimulation. I think at best I can say that TMS has a very limited role in Parkinson's disease. It has a palliative role in mild cases. Depression is a major component of these patients, and TMS works wonders in depression patients, major depression patients. So they improve a lot. They feel better, and just because they feel better, they're able to accept the physical disabilities and discomfort that they have. And I think with the availability of the double cone coil, which I think it penetrates the cortex further, I think we need to do more and more studies using different coils, different points of stimulation before we come to any sort of conclusion. But as of now, we have used it mainly where depression is predominant complaint, and patients who don't want deep brain stimulation and are not getting adequate control with medicines. These are the subgroup of patients whom we offer TMS at present. But overall, it's not very rewarding. We have not cured any patients of tremor, but like stroke, for conditions like stroke, patients have dramatically improved. They've gone back to work. That type of results we have not been able to reproduce in Parkinson's disease. But I think we should still not give up. I think the jury is still out, and I think we need to work harder, identify new areas of stimulation, and then hope that this treatment would be useful for these patients in the future. Thank you. If you have any questions, anyone, I'll be happy to answer in this regard.